the current pandemic. The first one is there will be significant increase in need for palliative care because COVID-19 patients and their families, those who have severe disease, will need palliative care provided to them. Secondly, we're seeing major challenges to the continuity of the provision of palliative care for existing patients. Those challenges in large part, of course, are due to lockdowns, travel restrictions, separation separation of patients from families and from health providers, challenges because of international travel restrictions, challenges to potential stockouts of medicines as a result of this kind of scramble to respond to the pandemic. Then obviously there's a huge risk for both palliative care providers and for patients because of a lack of personal protection equipment. And I think it's important to keep in mind that in palliative care, so many of kind of the essential providers in palliative care are community health workers, are volunteers. They are not the kind of frontline health workers that we tend to think about who when there are discussions about providing personal protective equipment. Then I think we are seeing an incredible increase in the need for psychosocial and spiritual care, both for patients and families with COVID-19 who are separated, families who can't visit people who are dying in hospitals. But of course, you have similar kinds of dynamics with a lot of existing palliative care patients who may be hospitalized and where there are restrictions on visiting hours. And so we're seeing both an increased need for psychosocial and spiritual care and a much more difficult situation for actually delivering that care. And then the final point or the final challenge that I wanted to briefly touch upon is this question of scarcity of resources. And I'm sure Lisa will talk about that as well, and how ethical principles apply to this. But we see so much discussion now about the risk of scarcity of resources or the reality of scarcity of resources and rationing of health services as a result of that. And obviously, in addition to raising questions of ethics, that also raises questions of human rights. So Stephen, can you go to the next slide? So a few words on kind of general principles, human rights principles in emergency situations. So it's important to start by just saying that an emergency does not just cancel out the right to health. Obligations under the right to health continue to apply to all states, no matter whether or not they have an emergency situation, no matter whether or not they have kind of formally declared an emergency. That doesn't mean, however, that states don't have, cannot legally take, impose certain restrictions that might affect people's right to health. So, for example, travel restrictions may have a significant impact on the delivery of healthcare services. Those travel restrictions may not be illegal or limiting visiting rights in hospitals obviously has an impact on the right to health that may be legal in certain situations. However, the right to health very clearly states that those kinds of measures that restrict people's enjoyment of the right to health can only be put in place after careful consideration of all alternatives. And so they have to be kind of the least invasive or the least impactful alternative, and they must be duly justified. So states can't just impose restrictions that don't actually kind of pursue a really legitimate goal or that are proportionate to the goal that they're pursuing. Stephen, next slide. So, how do human rights norms apply to these various challenges that I outlined? So first, when it comes to healthcare services, the right to health identifies four kind of basic pillars. Services need to be available, they need to be accessible, they need to be affordable, and they need to be of good quality. All of those basic principles continue to apply in an emergency situation. Now, obviously, there are some there are challenges with resources, and so the level of availability and accessibility may vary from country to country, but services have to be available in a way that is equitable, so that the poorest can access services just as the rich. Services must be provided in a way that is non-discriminatory. So you cannot provide services to one ethnic group but not to another, or impose other kinds of arbitrary restrictions on who can or cannot access health services. The second point, and I think a very important one, the right to health holds that states must respect and protect health services. So that means that states cannot interfere with the delivery of health services. But what we are seeing, of course, is that travel restrictions actually do interfere with the delivery of health services, because in some cases, people cannot travel to health centers or need special permissions in order to be able to do so. In some places, there are restrictions on health workers traveling to visit patients. Now, these kinds of restrictions, to a certain extent, are legal, but they have to be necessary. And so states need to make sure that they are not imposing restrictions that unduly limit the ability of palliative care providers to continue to provide care. And this is here, we face some challenges because a lot of palliative care providers are not formal employees of national health systems. A lot of palliative care programs work with volunteers. In a lot of countries, community health workers play an important role in the provision of palliative care. And so states, as they impose travel and other restrictions, they have to make sure that they make exemptions for palliative care workers, even if those palliative care workers are not part of the formal healthcare delivery system, because otherwise palliative care patients will be arbitrarily or unduly stripped of access to services that they need. An important principle of the right to health is quality of services. And obviously we are suddenly, I mean, we're seeing an entirely new phenomenon. We are seeing a new disease that has a certain kind of set of symptoms for which there was no clinical guidance on how to manage those symptoms. And so it is critically important for states and obviously for WHO and for organizations like um, the four host organizations of this webinar, to be working on ensuring that there is clinical guidance on how to properly provide care for palliative care for people with COVID-19, to provide appropriate psychosocial and spiritual care to patients and family members, guidance on how to provide that care in a situation where patients and families might be separated from one another. And so governments have a duty to make sure that that guidance exists, and that guidance is accessible to healthcare workers. Then the fourth point, the right to health is not just about physical health. Mental health is an equally important objective of the right to health. And so, you know, kind of with the situation that we are currently in, I think we are all hyper aware of the psychosocial and spiritual impact that this pandemic is having on patients and their families. We've all seen the images of people dying in isolation in intensive care units, with families sitting at home uncertain whether they will ever see their relative again. We've seen the impact of families who cannot bury their loved ones, of body bags stacked in temporary facilities, in refrigerated trucks, etc. This crisis is having an enormous impact on mental well-being, and so there's a huge need for palliative care providers to step into the fray to meet that need. And governments have a duty to make sure that the resources are available to provide those services, to make sure that health workers who are going to be responding to the COVID-19 pandemic in countries that are not too heavily affected yet, to make sure that they are actually properly trained in providing those kinds of services that in many countries have long been neglected. Um, then the next point, the right to health obviously focuses a lot on people who experience illness, but it also has very clear standards on healthcare worker safety, occupational safety. And so the right to health includes a duty for governments to make sure that people have, that healthcare workers, including non-professionals, such as community health workers, have access to as much PPE as can feasibly be provided to them, and obviously access to information about how to take protective steps. So very important. The right to health also provides protections to people who are providing palliative care. And then the final point around scarcity and rationing of care. Now, the right to health, it really doesn't say much about rationing. It does not prohibit rationing of care. What it does do, it provides a framework for how decisions are made about dealing with scarcity and for dealing with potential rationing of care. So it requires a decision-making process that is based on facts, that is based on evidence, that is transparent, that is clearly communicated, so that it is completely clear how decisions are ultimately made about how what care is available to whom. Now, obviously, it doesn't allow for kind of rationing of care across the board. What still applies is that countries have to put the maximum of their available resources into making sure that everybody has access to the care that they need. But the right recognizes that not that kind of levels of resources will vary from country to country, and that it is not rational or not possible for every country to provide the same level of care. And so it lays down some basic kind of rules for how decisions should be made in case there is scarcity of care. Stephen, next slide. So I'm coming to the end of my presentation. The final things I wanted to say is that I've outlined some of these basic principles of how human rights norms apply to the pandemic and to the palliative care response. Now, obviously, human rights organizations use these principles in order to actually, to make sure that human rights violations aren't happening. And so there's an important need for organizations to be monitoring, are governments actually living up, are they implementing these principles and these norms? When they aren't, in what ways are they not? How many people does that affect? To really start, we need to be documenting violations of the right to palliative care in these pandemic circumstances so that we can push back against situations where governments are indiscriminately imposing restrictions on travel that have a disproportionate impact on palliative care patients, so that we can start challenging those kinds of situations. And obviously, ultimately, I mean, these are legal norms that countries have to comply with. And so there is the possibility of actually going to court. Say a country imposes restrictions on travel, does not make any exemption for community health workers that are essential to delivering palliative care, that could potentially be challenged in court as an undue restriction. Or if countries have very strict limitations on prescribing of morphine, say, there's a 2-week limit on prescriptions, but it's become impossible for patients and their families to travel to get a new prescription every 2 weeks and to go to the pharmacy every 2 weeks in order to get a prescription. And in fact, it exposes them to COVID-19. Countries that are not willing to make an exemption and allow for, say, a month or a 2-month prescription of the medicine, those kinds of restrictions could be challenged potentially in court using human rights norms. And so it's important that all of us, and that means both human rights organizations as well as palliative care communities, monitor these kinds of situations, document what is going on, so that we can then start looking at how can we make sure that we force governments to make the accommodations that are needed to ensure that people who need palliative care actually continue to have access to it without interruption. And I will leave it there, except to note that this presentation is based on a briefing note that I don't think is available yet on the website that Stephen mentioned, but it will be soon. And it was co-authored by the people you can see on the slide, Frank Brennan, Bethany Brown, Liz Gwither, Fatia Kiyange, Andrei Arhansky, and myself. And I want to thank them very much for all of the input that they have provided for the briefing note and this presentation. Thank you very much.
Well, thank you very much, Diederik. We really appreciate your expertise and advocacy for palliative care. which I think we've made a strong case for, is a human right, access to palliative care. And universal health coverage is key to achieving that right. The location for the briefing notes, by the way, there are over 20 briefing notes that will eventually be prepared as part of this series and linked to this webinar series. And the location is on the flyer that we sent, but it's globalpalliativecare.org. It's a subpage of that. I just want to mention for attendees that we aren't going to be able to use the hand raise function due to the size of the audience. So please do, if you have, put your questions into the chat box, and we'll be collating those to try to address those at the end of the formal presentations. Dietrich mentioned that the right to access to medicines is one of the key issues in human rights, and our next speaker will be addressing this issue directly. I'm pleased to introduce Sami Ahmed, we call her, who is a clinical pharmacist and clinical professional for the Department of Clinical Health Professions at St. John's University College of Pharmacy and Health Sciences in New York. She's also a board member of the IAHPC, and we're pleased to have her. Sami, over to you.
Thank you, Steve. Thank you so much for the introduction. Good morning, everyone. Good afternoon and good evening, regardless of where you are. Thank you so much for the opportunity to be here today to talk about such an important topic, just like we heard also human rights and access to medications and availability during this very difficult time of the pandemic. So I'm going to be presenting the briefing note that was put together by a group of experts from different organizations to recommend the urgent action needed right now to improve access to internationally controlled essential medicines in all healthcare systems during this current time of the pandemic. Next slide, please. This briefing note was co-authored by the following members: myself and Jim Cleary from Indiana University, Liliana DeLema from IHPC, Matt Field from UNODC, Catherine Perez from IHPC, Lucas Rodbrook from the University of Bonn, Dr. Raj Gopal from Palam, India, and Christophe Rirat from WHO. Next slide, please. So just to give you a little bit of a background regarding the current situation, there is, as a result of the pandemic, we are seeing healthcare system. There's a wide access to, hold on, I just gotta move this. Okay, sorry. So there is an urgent need to increase system-wide access to internationally controlled essential medicines for patient care in response to the COVID-19 pandemic. Healthcare systems are required and ethically and morally required to have a complete adequate supplies of internationally controlled essential medicines to manage the variety of symptoms that could be a result of patients being infected with COVID-19. Prior to the pandemic, the Lancet Commission on Palliative Care and Pain Relief, published in 2018, estimates that more than 80% of the world population lack adequate and effective access to internationally controlled essential medicines. And the majority of these countries, actually, and the majority of these patients resides in low and middle income countries. Many, we have seen now, we were following the media, we have seen many reports coming out from the United States and from the European regions, coming out sending alarming reports about the shortage of these medications that are needed, that are essential. They go hand in hand in providing symptom relief for COVID-19 patients, or for needed also for the ventilators. And as a matter of fact, the American Society of Health System Pharmacists here in the United States issued a statement saying that more than 600, the demand went up by more than 600% over the last months, even though even hospitals are not even using these medications for elective surgeries. There are many using them for COVID-19 patients who are coming in with symptomatic symptoms. Next slide, please. Acute respiratory distress syndrome and dyspnea resulting from the COVID-19 disease may range from mild to critical creating some type of a distressing sensation. A lot of patients come in complaining of difficulty breathing. They feel like they cannot breathe well. They feel suffocating. They feel like the air is not enough. And the management of these symptoms oftentimes require that some of these patients, if they're coming in with critical symptoms, they're going to be going on a ventilator, which requires that the patient has to be sedated prior to putting them on a ventilator, which requires using some of the internationally essential control medicines like benzodiazepines, like diazepam or midazolam, or opioids even to sedate the patients. And the clinical management of breathlessness or anyone who's having like air hunger or difficulty breathing is oftentimes also relying on the use of low doses of like opioids, such as like morphine or fentanyl. Management management, again, as I mentioned, includes mechanical ventilations, which requires that the patients could be sedated. So we need these essential drugs. And if anyone is listening today is familiar with Section 2 of the 2019 World Health Organization's model list of essential medicines, it highly recommends that all member states should have this essential medicine list for palliative care, which includes opioid analgesic that could be commonly used for pain and respiratory distress, medications again like morphine and fentanyl, as well as sedative and anxiolytic substance such as midazolam and diazepam. Next slide, please. The International Narcotic Control Board, which is the governor body required or mandated to support member states to ensure compliance and to make sure that availability of internationally controlled substance for medical and scientific purposes. Should every country's, they ensure that every countries have special stocks for humanitarian emergencies and crises. And clinicians treating COVID-19 patients may be very unfamiliar with the use of opioids such as morphine in this acute context, especially if they're not trained in palliative care, whether you're a nurse or a physician or a pharmacist. If you're not trained in palliative care or understanding like the use of opioids for the management of breathlessness, you're going to be very reluctant about using these medications when needed. And just like we heard from Diedrich, according to the United Nations Special Report on torture and pain relief, everybody has the access, every patient should have access to pain relief if it causes severe pain and suffering that could be inhumane or degrading treatment or punishment. Next slide, please. Healthcare service also in high-income countries are running low. As I mentioned, like in the United States, we're seeing reports, and in European countries, we're seeing reports, keeping in mind that the recurrent stockouts are already endemic in low and middle-income countries, and will be exacerbated with double, more patients are going to need palliative care, more patients are going to be going on ventilators, more patients are going to need to be sedated, more patients are going to require symptomatic relief. And the WHO and the National Palliative Care Associations are reporting also, that's an interesting thing that we're seeing right now, that the prices from the pandemic is going up, driving because of the demand. The demand is going up, and also the lockdown stress the supply chain, this international, no, go back again, Stephen, sorry, next slide.
Oh.
It went back, I'm not sure why. Yep, right here, okay. And as a result of this lockdown, and we are seeing this exportation restrictions in many countries, including Europe, which could directly impact the availability and the affordability of the internationally controlled essential medicines. We are seeing like many countries are locking down their land and sea and air cargo, so that could totally affect like supply chain. If anyone is familiar, on March 17 of this year, 2020, the International Narcotic Control Board issued a recurrent report calling on government to ensure continuing access to controlled medicines for pain relief and palliative care during this COVID-19 pandemic. The board also calls on the national authorities of all countries and territories to ensure that every country should have sufficient buffer stocks of controlled substance to guarantee that they're going to become available when needed through the duration of the pandemic. They also issued in their statements, they wanted to make sure that authorities have enough supplies, and highlighted how distributors also play a crucial role in ensuring that internationally controlled substances urgently needed for medical treatment remain available within and across national borders. Next slide, please. So some of the recommendations from the briefing note that we came up with as a group of experts is, since many healthcare professionals, including physicians and nurses and pharmacists, may not be familiar with the use of opioids or benzodiazepines for COVID-19 symptoms, specifically like dyspnea and breathlessness, we recommend an accelerated training, clinician training, and using online right now, specifically like any of the platforms regarding the use of opioids and benzodiazepines for COVID-19 related symptom control. So training specialists is extremely important, and in particular training specialists to prescribe and deliver opioids in low income countries. So looking at the model from Uganda or Rwanda, where they trained nurses in home set to deliver care at home settings. And that actually aligns with the WHO calls to invest in nurses in this International Year of the Nurse and Midwife. We also recommend that these extreme restrictions on internationally controlled essential medicines to be lifted during the pandemic time, to make it easy for the supply and chain to continue, and to make it easy for exportations of these products to be coming in the countries. We also recommend the increased productions of internationally controlled essential medicines to meet the high demand that we are seeing right now. The UN agencies already issued a joint statement to member states recommending for them that they should increase their productions, because especially with the demand going up. Next slide, please. We also recommend for countries to identify, member states to identify manufacturers to produce cost-effective generic bioequivalent internationally controlled essential medicines. So this is a great opportunity for countries to think about starting producing morphine on the ground. Morphine in general is extremely very cheap. It's not expensive at all. It could be made within the countries as long as they have the right supplies that's needed to make it. So we should take advantage of this right now and encourage countries to start making their own morphine using the model again of Rwanda and Uganda. And we should also, we recommended that mechanism should exist right now in terms of funds in global and regional entities to make sure, such as development banks or collaborating with procurement partners, including humanitarian agencies, to increase regional and global buffer stocks. We also recommend that member states to maintain supply chain operations, making sure that they have an adequate protections of warehouse stocks, pre-export inspections, safe transportations for drivers, make sure that they're using the right precautions and functions, also customs service, and also to protect our healthcare workers who are on the ground going to see patients every day at their homes, make sure that they are protected as well. And in consultation with the WHO and the UNODC, we recommend a mandation of the formation of a multi-stakeholder task force that includes healthcare providers and national narcotics enforcement personnel to accurately assess the current situations on the ground, to make sure that we have a current data, we have the actual data regarding the current situation and what is needed on the ground in terms of supplies, in terms of procurement and preparedness for this during this time. And to review national regulations on access. This is an opportunity for all member states to review their own national regulations on access to internationally controlled essential medicines for medical purposes, to ensure that they contain exemptions for humanitarian emergencies, and make sure that they have adequate supplies when needed, especially during times of emergencies. Also, in many of these low-income countries, unfortunately, a lot of these opiate prescription medications are only stocked in inpatient hospitals, so it becomes very problematic for patients who are living in rural areas, or patients who are living very far from hospitals, or in regions or rural areas where there's actually no community pharmacies to dispense opioids. So we recommend that inpatient hospitals are allowed to dispense opioids to outpatient palliative care patients. They don't necessarily need to have COVID-19. Normally, they go to their outpatient pharmacy, or they have to go like drive 2-3 hours into the city to get these prescriptions. But because of the restriction right now on the, because of the lockdown and patients getting out of their house and going to the city, we recommend that hospital pharmacies are allowed to dispense opioids for these palliative care patients. So that is a briefing note, and I think we need to get data. We need to get a lot of data regarding the what's actually happening on the ground regarding the current situation in different regions to ensure that these essential medicines, whether it's opioids or benzodiazepines, remain available and accessible and affordable for patients who need them. Thank you, Steve.
Great. Thank you very much, Sammy. A very, very important topic that continues to be a real major issue for palliative care access globally, and an ethical issue to ensure that we have access to medicines that are necessary. And leading into that, our next speaker on the topic of ethics is Professor Lisa Schwartz, who's the Arnold L. Johnson Chair of Healthcare Ethics at McMaster University and Senior Investigator in Humanitarian Health Ethics. Over to you, Liz.
Thank you very much, Stephen, and thanks to both the pre-speakers. Everyone's set this discussion up so beautifully, and I think we've got a good sense of the high stakes really that are involved. The group that collectively authored the bioethics principles, practices, and recommendations relevant to COVID-19 pandemic and palliative care for all patients who need it includes Suzy Ceruzzi, Nunziata Comaretto, Richard Hain, Bruce Jennings, Catherine Pettis, Steve Radwani, and myself, with help from Liliana de Lima. And when we set out together, next slide, please, we worked on a background of the same sorts of considerations and alarms that have just been described in the last two talks. But the judgment, the final sense about it was that we were wending our way to a statement along the lines that palliative care is essential to provide physical, psychosocial, spiritual support for patients, for their families, and for the practitioners in the context of COVID-19 pandemic. Which I think it helps us to understand that there are three sets of stakeholders in this category. It isn't just the patients who will benefit from palliative care and access to these resources, but their families as well, and the healthcare practitioners who will find that when they are stuck at the bedside, feeling helpless with nothing, a sense of nothing to offer, will know that they at least can rely on the supportive care that comes with managing the suffering of patients of various different stages. So one risk of this pandemic is that not all patients needing care are going to receive proper standards of care. And that's a reality that is borne out across jurisdictions and is likely to happen more so as we move along. The circumstances and escalating demand limit resources, and it means that healthcare providers have to face hard choices, choosing about treatment directed to those with better prognoses, reconfiguring services so that people who feel that they urgently need it may not get the services that they need, and then the ethical guidelines that we need to ensure that humane and respectful treatment and care of all patients, no matter where they find themselves in access to traditional standards, will still feel that they're not abandoned by healthcare practitioners. And so there's this additional challenge for physical distancing and isolation that we've already heard described, that makes it harder for patients to feel connected and supported by loved ones. And care providers are often filling that gap at this time. Next slide. The widespread social and economic breakdown is emphasizing some of this, the uncertainty and anxiety and scarcity of essential healthcare resources could lead to erosions of trust among the community, who have a sense that they may be singled out as not receiving healthcare and the kind of healthcare benefits that they want, and a sense also of being abandoned. Next slide. So this is why we turned to the establishment of just and fair rules of allocation of scarce resources, whether those resources be ventilators on the grand scale, but also the personal and protective equipment that is so much needed at this time and so rare and becoming scarce, as well as the essential medicines that Sam just described. In many countries, they'll find it especially challenging to locate even the human resources, as well as the financial resources to respond adequately to the needs of all who need it. And so personnel and medications and equipment necessary for palliative care are all scarce resources that require just and fair rules for the development and allocation that must be developed. And so we situated ourselves with a sense that there needs to be high levels of personal and institutional solidarity across not just local jurisdictions, but globally, and a strong integrity of healthcare providers and decision makers. Next slide. Of the principles that we identified, it's not surprising that non-abandonment was the first one. That patients should not only not feel abandoned, but really cannot be abandoned in the process of this care. And it is difficult, but we've seen it happen gloriously, really, with even to the personal sacrifice of individuals, but without needing to impose on healthcare providers to take on too much sacrifice. Healthcare decision makers also have to recognize that they play a role in the principle of non-abandonment. Also showing and demonstrating respect for persons at all stages of healthcare, and respect also for their autonomy and their choice making, giving people plenty of information to understand that the decisions that are being made partly with their own interests involved, and also for public health reasons, and that only restrictions for very compelling reasons will lead to hard choices being made, but in the end that individuals won't be abandoned. We also turned to confidentiality and maintaining the confidentiality of participants, or sorry, of patients in all contexts as being crucial. So only in the most restricted sense should information be shared for compelling public health reasons. And then the principle of reciprocity, which is always, in the background of this, we wouldn't be able to do this work if individuals who take the highest of risks, frontline workers in many jurisdictions, need to understand that they will be protected as well, and that we will do our best to maintain and ensure safe working conditions for them. Justice and fairness was the last of the principles that we identified in the first core, and with an understanding that patients with similar health conditions will be given equal access without discrimination, and that decisions will be made on the basis of clinical decision making and not for any social or political reasons at all. Next slide. In order to apply these, we also identified further principles that help to govern the allocation of scarce resources, with one of them being transparency, and a strong recommendation that the rules of decision-making for scarce resources be prominently posted and available for anybody who may seek to question or be affected by them at all. And that this also includes various principles in the development of those standards, including inclusiveness, so that stakeholders feel that they are heard and that they are able to participate in the development of and the upholding of governing principles for scarce resources, transparency on how those rules are developed and the reasons why, as well as accountability, which includes an appeals process when individuals feel that their rights are being violated unnecessarily or unfairly in the decisions that are made. And finally, of the last of the principles, consistency and responsiveness, so that the application of them will be made fairly, and that individuals will also understand that their needs are responded to, even if it means certain hard decisions need to be made. Next slide, please. This all comes on an understanding that we recognize that vulnerability happens at many stages and in many ways. And while we're all feeling very vulnerable in the context of COVID-19, and that isn't surprising, there are some people who live with greater vulnerabilities. I think we've heard statements about the democratization of the global context through COVID-19, but the reality is that some people will be affected much more severely by restrictions, by infections themselves. So there's an obligation to understand that social vulnerability, like homelessness, like statelessness, and other circumstances mean that that it may require more and more intense psychosocial services associated with palliative care and other kinds of treatments in the context. Also, patients who live with chronic illness and disability may require enhanced protective measures so that they don't find themselves needing even to go into hospital. We need to recognize that within the community, we need to respond to make sure that they don't become unwell and find themselves competing for resources that are already scarce. And then finally, the best interests of the child, UNICEF's statement about the access to care by children. So the care of minors will be governed by this, this principle. On the next slide, almost my last slide, second to last, we have a series of recommendations that were made. I can't go into detail on all of them, but this statement is also going to be posted and made available, I think in the coming days, quite shortly. But many of these focus on patients, while others of the recommendations focus on the healthcare providers themselves, and some are directed at decision makers. So ensuring the reciprocity, again, of protection for individuals who take the highest of risks to provide care is very important, and that includes access to PPE, to testing, to treatment eventually, and also to the psychosocial support that will help them manage the stress and the trauma of the, I guess, the ocean of need associated with COVID-19 and other care and treatment. We also recommend the appointment of a committee that's unbiased in the circumstances and can and appropriately trained and supported to make the allocation decisions, so that individual clinicians at the bedsides don't have to find themselves making those hard choices individually by themselves and without support. Then the decisions should be based strictly on patient need, and not on socioeconomic status or identity. The decisions, as we said before, need to be made available and public with an appeal process that gives everybody the opportunity to be heard, even if they don't have their wishes satisfied. We need to prioritize scarce resources and include in those priorities not just duration of life and decisions about who could live the longest, but also think about benefit as being the benefit of a quality of life for the life remaining. include palliative care pathways in all triage policies. In the past weeks, I have seen policy after policy come up about decision making regarding triage and access. And so many of them forget that at the point at which they're saying no to an individual patient, it's necessary to indicate the pathway that they will receive care in, and that this usually is palliative care. We need to understand that that we can only begin or should only begin interventions that will be of benefit to the patient, and likely outweigh the harms of that intervention. And keeping in mind too that if a patient has refused and has the capacity to refuse, that intervention should not be started on them without their consent. And then finally, optimizing the communication with patients and families. In some jurisdictions, I've seen an individual appointed specifically for a given family to give them a point of contact that they feel they can trust, and somebody who they feel is passing on the information and maybe even providing advocacy for them. So the final slide, we really come back full circle to where we started, that palliative care must be provided to all patients who need it, regardless of their prognosis. And it is an ethical imperative for those not deemed eligible for life supportive care. Thank you.
Thank you very much, Lisa. That was a wonderful presentation, and so many key issues that ethically that have been raised by the pandemic. And really, I mean, in some respects, palliative care, I think, is people have become more aware of palliative care as a result of all this whole experience. We have a half hour left, and we now have quite a few questions, 47 questions in the chat box. I'll remind people we aren't able to use the raise hand function for this webinar, but we will try to address your questions as best we can. And to help us do that, one of our team, Kate, has been collating in the background. Kate, are you able to begin raising some questions for our panelists?
Thank you, Stephen, and thank you to all the panelists for these excellent presentations. So I'll just start with a couple of questions about the right to health. Deirdre, across the globe, we are seeing that due to overburdened health systems, people needing treatment for emergencies or conditions other than COVID are often not accessing care. Can you speak to this from a right to health perspective?
Yeah, I think, I mean, that is a huge problem, and it's something that obviously, I mean, the right to health, as I mentioned, in an emergency doesn't just stop existing, and that is not just true for patients who need palliative care. It's for all patients. I actually, this maybe gives me an opportunity to respond to two questions at once. I noticed there was also a question about, you know, the duty of governments to protect the health of their citizens. And the question here is, they're clearly, under the right to health, governments have a duty to protect their citizens. The question is, what are the measures that a government imposes, and how are those measures calibrated? You know, we could say if a government has a duty to protect citizens from, you know, being killed in a car accident, one measure could be just banning all cars altogether. But none of us would consider that, or most of us would not consider that a viable option. So we want measures that are imposed that find kind of the right balance between allowing society to continue with economic activity, but also protecting health. And so what we need in this situation are measures that carefully, you know, that are based on science as much as possible. Obviously, that is challenging in this situation because it's so unprecedented that we don't yet know really what, do we need to close schools? And clearly closing schools has all sorts of impacts on, children's right to education, on children's health. In the US, a lot of children depend on schools for, for meals. So we don't know yet what the right package of interventions is that can help us control the pandemic. So the kind of the science is still unclear, but what a government can do is really carefully look at what are the unintended consequences of some of the control measures that we are putting in place. So, is one of the unintended consequences that people who need other kinds of healthcare services can no longer access those services, or the governments, can think about, well, what are, how are people responding to this crisis? How do we need to facilitate continued care for patients who don't have COVID-19? And so, I've seen in my sister works as a nurse at a hospital in the Netherlands, and their hospital has two branches. And so one is where they do all of the COVID-19 care, and the other is they don't do any COVID-19 care. So, they've kind of thought through ways of making sure that patients who don't have COVID-19 can still feel safe going into the healthcare facility to continue receiving the care. So it's really all about making sure that the government response is carefully calibrated to make sure that control measures don't have a disproportionate and unnecessary impact on patients' ability to continue to receive care, and anticipating some of kind of the behavior changes that you are seeing in patients as a result of the pandemic, and proactively making sure that that you address those behavior changes to minimize the harm that comes from, for example, people being reluctant to seek care for, for regular health issues.
Thank you very much. The second question, also for you, Deirdre, it has two parts. The first part is, could you tell us which human rights treaties specifically mention palliative care? And then the second part is, which remedy options can be identified in relation to right to health violations, such as going to court, which venues, and under which instruments?
Great, excellent questions. So in terms of treaties that specifically mention palliative care, there's actually only one treaty so far, and that is a treaty of the Inter-American human rights system. It's a treaty that focuses on the rights of older people, and that has a number of pretty detailed provisions on palliative care and the duties of a state to provide palliative care. Otherwise, palliative care is part of kind of the general, the general right to health. So it's not specifically mentioned in other treaties, but there's a broad consensus now that the right to health includes a right to access palliative care. The question about specific kind of remedies is a challenging one. Most international human rights treaties don't have a true court attached to them. And so these are treaties that are, not legally enforceable in a court. They can be used in the court of public opinion to argue that certain restrictions for example, violate these norms, and that a government needs to take action to address them. But that's obviously a court of public opinion, not a court of law. In Europe and in the Americas, there are human rights courts that could potentially play a role in adjudicating cases related to COVID-19 response and palliative care. However, they are really they're a last resort, because the processes in these court often take 5 to 10 years to be adjudicated, and we're dealing with an emergency situation. And so, they're very useful for setting a precedent in the long run, but they're not very useful when people are, not able to access services right now, and those, those challenges need to be resolved right now. National legal systems vary tremendously. In countries like India, South Africa, there are right to health provisions that can actually be taken, where cases can actually be taken to court. In a lot of other countries, you don't have a kind of nationally defined right to health that is what is called as judiciable, that it can be the basis of a legal case. However, most countries have provisions, for example, on freedom of movement, and those kinds of provisions are actually can be judiciable, and so in case someone cannot access care because of restrictions that have been placed on their right to movement, one could potentially go to court and argue that the restrictions on right to movement are so far-reaching and are unreasonable in that they deprive someone of an essential service that they need access to. But even at the national level, court proceedings can take a long time. And so I think in some ways, kind of human rights norms are maybe more effective in terms of using them to do public advocacy, to do media work in order to draw attention to to consequences of the pandemic, or of the response to pandemics that are causing harms to specific groups of people, including palliative care patients, and to really seek to resolve these issues through through public through kind of the court of public opinion rather than the court of law.
Thanks very much, Deirdrick. So the next question follows on from your presentation, but I think it's addressed to all the panelists. It's that you mentioned that the right to health encompasses both physical and mental health. And the participant wanted to know, how is mental health being monitored in people with palliative care needs during the COVID-19 pandemic?
I'm not sure who's going to answer that, but I'll jump in and just start. As the clinical psychologist here among us, I think any palliative care service has to establish that has to have mental health staff working. Most commonly, we see social workers, but there should also be other mental health professionals, psychiatric nurses, psychologists, psychiatry available at least to help. And all the team, the nurses, aides, everyone should be trained in being able to identify patients who are having significant mental health issues, depression, anxiety, grief issues, etc. And that's just fundamental to palliative care, whole person care, that we're paying attention to those psychological issues. Any other comments from panelists?
So I'm not sure that I know of any formal monitoring across jurisdictions. But I mean, I'd echo what you said, that it's understood that it's an essential aspect of palliative care includes psychosocial and spiritual counseling, and not just for the patients, but for their family members, and also for the care providers. So it should be there, but whether or not there are any measures, I guess I would turn it over to colleagues to describe.
I think to me, this pandemic has really emphasized the importance of the palliative care community working with mental health and rights communities. Unfortunately, I think in many countries, the kind of the collaborations between those two communities have not, are not very well developed. Clearly, there are going to be organizations that work in the mental health space that are going to be doing monitoring of kind of the impact of the pandemic on mental well-being, the response of governments to that impact. And in particular, I think there's a real fear of the kind of over medicalization of anxiety and sorrow that is a natural response to all of us living in a pandemic. I mean, frankly, I read one blog recently by someone who works on mental health who said, in fact, we should be more worried about people who don't feel anxiety today than about people who do feel anxiety, because this is a normal response to a highly unusual situation that has disrupted all of our lives. And so I think there's a real opportunity for the palliative care community to come together with the mental health and rights community in order to start looking at what is the impact on palliative care patients, but also more broadly, and what kind of response do we need to those impacts? Because I don't think the response needs to be to start prescribing, pharmaceuticals to everybody who experiences anxiety or sorrow. The response need to be to help people develop coping mechanisms to deal with what is a natural response to this kind of situation. And obviously, for palliative care patients and for families of people who die from COVID-19, the grief that they feel and the hardship that they feel because maybe their loved one died alone in an ICU, and they weren't able to bury the loved one. They weren't able to, organize a memorial service the normal way. I mean, all of that has impact. But that shouldn't be medicalized. We should provide the appropriate psychosocial and spiritual support to people in those situations. And so I would really encourage collaboration with mental health communities in order to start up that kind of monitoring. At this point, I'm not aware that there is any structured effort to do that kind of work.
You mentioned that in May, we're going to be doing one of the webinars that we're going to be doing as part of this series will be focused on mental health issues, suffering alone, as well as grief and bereavement, responses that are somewhat unique, as Dietrich has pointed out, to the pandemic. Let's go to another question, Kate. That's maybe something on that.
Thank you very much, Stephen. Thank you to everyone for your responses. The next question is for Sammy on essential medicines. Could you tell us more about what are the sources of opioid production, and can you elaborate on how production may be escalated in the immediate future?
Okay, thank you so much, Kate. So that's a technical question regarding like the production on the ground. However, if you followed the INCB report that came in March 2020 of this year, I think this is an opportunity for all member states to use it to advocate for increased production on the ground by talking to local manufacturers, by establishing like systems on how to make the opioids available and all essential medicines. So taking advantage of that, like in the sense of like they can advocate to the Ministry of Health, calling, because this is now like the governor body, to make sure that these are available. So they can go to the Ministry of Health or go to the national authorities, whether they are regulatories or whatnot, and encourage them that now we need to increase supplies and distributors. But as far as like how to do that on the ground, I think that's a technical question. I think we have people here on the panelists from WHO who can answer that question, or UNODC. Right, Steve, or am I wrong? I think we have people.
No, we have one of our colleagues from WHO on the call.
Yes, thanks, Sam.
Christoph, yeah.
Different, yeah, Christoph calling from WHO Medicines and Health Product Division. And effectively, Samia already answered partially to this question. And during her briefing, the presentation of the briefing, she already covered many points regarding access and what the organization, in partnership with other stakeholders, is doing to mitigate the impact of supply chain disruption. For example, to stick to your question, we do not have a consolidated or official list of manufacturers and suppliers for the internationally controlled medicines and opioids. So what I can say is that many of them are based in Western Europe, basically in France, Germany, and Belgium, specifically for injectables. And there is also an important supplier, which is Serum in India, who is actually running, who actually slowed down his capacity of production because of the lockdown in this country. So this is something that we are closely monitoring with the International Association of Generic Manufacturers as well. We have 2 weeks, twice a week, a phone call with them to monitor the situation, the capacity of production, the risk of shortages of these products, the different bottlenecks that could affect or impact the access of this product. What I can say as well, that it's in routine, or let's say in normal time, the supply of these products is already at risk, and the availability of most of those products are very low. So obviously, with the impact of and the consequences of the COVID, we cannot expect that the supply will be optimum. But this is one of the lessons learned that we from this pandemic. One of the lessons learned will be to improve our capacity to work together, to improve our capacity to coordinate with the private industry and the association of generic and other manufacturers to improve access to these products. In routine, the organization as well developed many tools and services to monitor the accessibility of products. We developed recently a platform to monitor the shortages. There is the WHO alert for falsified and substandard product. That is of importance, because when we are talking about access, we also obviously need to address the issue, and first of all, the issue of quality of products that are producing. And unfortunately, as many other category of products, opioids and international control medicines are also highly falsified in the world, unfortunately. We also provide and supply these narcotics or opioids with international emergency kits. So there is quite a huge deployment of these kits actually in many countries. And of course, the limitation of the capacity of production actually limit the shipment of these complete kits. just one point on the PPEs, the prevention equipment and protection for healthcare workers, which is something that is critically important, and that was raised in the first presentation by Diederik at some point. We developed as well a disease commodity package, which is available on the WHO webpage, of course, that presents the different key equipments and medical products that should be available at any time, and especially in this time of crisis in the countries and for the healthcare workers again. So this is one of the point of consideration. Over.
Thank you, Crystal.
Steve, we also have Liz Matfield on the call. She asked to get a minute, if possible, to respond about what UNODC are doing.
Are you? I don't see. Lisa.
Yeah, Elizabeth Matfield. She said she's happy to share a minute of information from UNODC.
I don't see her in the panel function.
I think she's an attendee. Remember the whole thing about not getting the link? I think you're just gonna have to unmute her. I see her in attendees.
Let's hold on, Elizabeth. You. Here. Okay, Elizabeth, you can talk.
She has to unmute herself now.
Unmuted.
Thank you, Stephen, and sorry I wasn't, I thought you had all the power, and thank you for giving me just a moment. I wanted to share with folks on the call that as a reminder, each country has their own regulations and approach to controlled medicines, and that is one of the things that makes it a little bit difficult. But if you are finding that you are having shortages and you would like to access controlled medicines and look into different imports, please do look at your rules and regulations very carefully, because many countries have a stipulation during times of crisis that not only should you contact INCB and they can help to move that along quickly, but also that you would be able to accept aid. And UNODC and UNDP are looking at working together in terms of procuring controlled medicines that would then hopefully be considered under the category of aid for countries that do have that flexibility in their regulations. Currently, UNDP and WHO are working together on mostly procuring equipment, but we are starting to have the conversation about controlled medicines as well. So hopefully we'll have some positive information in the next few weeks.
Great, thank you very much. I think we have time for one more question.
Thanks, Stephen. So this question refers specifically to the United States experience, but lessons from other countries are also relevant. So the question asks about the issue of isolation of the patient from their family when the patient is a child, and notes that this is very worrying. So the attendee asks, what has been the experience in the United States in the management of children affected by COVID?
Lisa, do you have any comment on
that? So I'm based in Canada, and the hospitals that I've been in touch with, for the most part, have allowed a parent or a loved one, someone at the bedside, specifically for children who are conscious or children who are close to the end of life. I think these have been special permissions for across the board, but some of the hospitals had considered policy that would permit children to have support at the bedside. It means, taking time to carefully prepare parents or whoever it is to don and doff PPE carefully. It could mean a limited amount of PPE available. Sometimes individuals are told that if they come in one day, they can't come back and forth. They have to stay in the space, and that has created additional requirements, let's say, maybe burdens for social work and healthcare and others to provide the person at the bedside with support, like even just food and water. So it's been a challenging thing to do, but my understanding is that for children, exceptions have been made. I don't know about the US, and I'm not sure about other jurisdictions either.
Thanks very much. Julia, do you want to jump in on this?
Yes, I mean, it has varied in different countries. So I know of situations where children have not been able to have a carer, but we're certainly advocating that at least one carer should be available to be with the child. And I know here in the UK, there's been several instances where that has happened. Again, I think a bit like in Canada, sometimes it means the carer has had to be in the room and stay in the room then, and can't go in and out. But certainly the importance of children having a loved one with them has been recognised, both for children without existing complex conditions, but also for children with underlying complex conditions as well, because obviously the carer or the parent knows best how to care for them. So we are definitely advocating that children should be allowed at least one carer. How that works varies, and it's not always possible. It depends on the situation.
Thank you very much, Julia. So we're down to the just about the end of our session for today. I do want to note that at this point, we're planning next Friday to have also 3 presentations. One by Dr. Lucas Radbreck on symptom management of COVID patients. Also with a presenter, Carl Alexander, on infection control measures. And finally, cure of cancer patients in low and middle income countries with an oncologist, Dr. Dingle Spence from the Caribbean. So look forward to that next week. We're going to, once we have all these briefing notes done, we'll also have all of them up on the website for use. I want to mention that we do want you to use those briefing notes for advocacy purposes and for educational purposes with policymakers in your own countries. So on that note, it is now time for us to end our session. So I'll just remind everyone to be sure to wash your hands frequently and your cell phones, and be safe. Have a lovely weekend. Thank you all very much for joining us, and we look forward to future opportunities together. Take care. Be safe.